Welcome, everyone. Thank you so much for joining us at the Systems and Sustainability for Substance Use Disorder ECHO. My name is Andrea Roche. I'll be facilitating our conversation today. I just have a few quick housekeeping announcements before we get started. I want you to know these sessions, like all sessions from this program, are enabled for closed captioning. To access that, if that is helpful for you, just navigate down to the bottom of your Zoom window and click on the show captions option. You might need to look under the more menu or the three dots over on the bottom right of your Zoom screen to access that. If you're having trouble with any of those not very clear instructions from me, please do reach out to Kato with Echo IT and she can help you out with that. As you saw, we are recording these sessions and make them available after the session on our YouTube page. Know that any information you put in the chat will not be shared on those recordings. As always, we do ask that you stay muted unless you're speaking, but this is an echo, so we do encourage everyone to speak. If you joined on a computer, your mute button is in the bottom left of your screen. Just make sure you mute and unmute yourself. Just to control any feedback we might hear during the session. If you're on the phone, it's *6 to unmute. There are a lot of us here and that number keeps creeping up, which is terrific, but also just to help us with some attendance, enter your name and your email and your affiliation into the chat. Know that we encourage everybody to speak during these sessions, and you can do that either by unmuting or by sharing information in the chat. As a reminder, though, no PHI is allowed whether you're speaking or commenting in the chat throughout the entire session. Keep an eye on that chat. About 2/3 of the way through the session, we're going to send out a link. We do a slightly different process. Let me skip over that and I'll get to that in announcements. Anyway, we will send out a link for a post-session evaluation. We want you to fill that out and get yourself entered into a raffle to win a $30 Walmart gift card, and also give us some feedback on where you'd like us to go with these sessions. Really excited for our didactic and our case today. Lesley on our hub team is going to be presenting about establishing baseline metrics to identify progress in substance use disorder programming. And then after that, we have a really interesting systems case that I think there's a lot of experience on the call today to give some feedback for. So I encourage all of you to share your questions, share your feedback, share your guidance during our case discussion today. Remember, we are all teachers and we are all learners in this space. All right, with that, I'm going to do some introductions. I'll start with you, Lesley.
Hi, everybody. I'm Dr. Lesley Manson. I'm a clinical psychologist, a clinical associate professor at Arizona State University, and an international consultant for integrated care, team-based care, implementation, training and evaluation, and improvement. So thanks, everybody.
Thank you, Lesley. Kathy.
Sorry, I was having trouble with my mute button. Hi, I'm Kathy Hudgens. I am also a hub member. I'm a program builder and trainer for integrated care, and have been working in mental health and substance use integration for almost 2 decades. And I also am a member of ASU's Integrated Care ECHO.
Thank you so much, Matt.
Hi, folks. I'm Matt Rose. It's good to be with you today. My background's in clinical social work, agency administration, and governmental planning. I currently work as a consultant with technology transfer centers and a number of universities and research studies. Primarily work coaching and consulting and assisting systems with process improvement, quality improvement. Come from a NITEX orientation as a founding member of NITEX, and I do a good bit of evidence-based practice training as well. Thank you.
Great, thank you. And B.
Hi, good afternoon, everyone. B, or Bidiseva Cotois with UT Health San Antonio, Be Well, Texas. I'm the Director of Substance Use Treatment Services, and I've been in the field of treatment services for about 29 years now. Thank you.
Terrific, thank you so much. And last but not least, Andrea.
Oh, sorry. My name is Andrea Hebler, and I'm a program coordinator for the ECHO sessions, and welcome everybody.
All right, great. Thank you. Lesley, I will give the floor to you. Take it away with our didactics. Again, as she's pulling those up, use that chat feature to enter your attendance info in the chat. Thank you so much.
Okay, I just want to make sure everybody can see clearly.
Looks good.
Wonderful. And you can hear me okay. Perfect. So we're going to go ahead and move forward. I do want to let everybody know we will be sending out these slides. And in addition, we also have some extra supportive material if folks are interested that we can include in the follow-up emails. So basically, right now, we're going to start talking about starting the new year off right for all of your programs, really establishing your metrics for your programs. And we're going to walk through a way to be able to do that. So I want to first start with my disclosure that I am a member of the planning committee and I have no relevant financial relationships or commercial interest to disclose. Our learning objectives for today, so things I'm going to be reviewing and going over are, we're going to learn about nationally recognized organizations that provide standardized metrics for substance use programs. We're going to discuss different types of metrics for substance use program management, and we're going to describe how to calculate those metrics. Now, we only have about 20 or so minutes together, so it's quick. I'll go over as many examples today as possible, but please know we'll be sending out more information in that supportive material, and we'd love to hear from you. So at any point during this presentation, if you have any feedback or suggestions or questions, please feel free to turn on your mic and let us know, or throw something in the chat box. Okay. So with metrics and measures, it's essential to consider the best ways to showcase, optimize, and report your outcomes for your program. Reviewing your metrics and measures on a formal annual basis for all leadership and team review is essential and necessary. It's also important to keep regular quarterly scheduled meetings related to monitoring, development, and improvements to ensure that you're really meeting your aims. And we're going to go over how to do that in a little bit here too. Metrics and measures are a way to demonstrate your value and success as a provider of care. When considering those metrics and measurement choices, it's essential to consider alignment in different areas. So you want to consider your organizational mission, your program outcomes, your stakeholder area focuses, your stakeholders, that's including patients, communities, providers, staff, team members, and payers, right? Insurance companies, grants, local and state entities. All of them will have specific focus areas. And typically, we first start with a stakeholder meeting or multiple stakeholder meetings to identify the focus, aims, or priority or areas for our organization or our metrics. Okay? Most of those stakeholders may also have required metrics. So just to first start and opening it up, here are some of those stakeholders that you may be working with now or required to utilize their metrics for substance use. This is a great place to start if you're not aware of required metrics to ensure that you design your metrics and measurements following national and international standards and recommendations. This will also help you for future reporting, your value-based negotiations, which are continuing to increase, for payment improvement opportunities, and just simply for sharing your value to your other community members for grants and other support. These metrics are often tied to data pool capacities in most mainstream EHRs. Because they're international and nationally recognized, you can utilize these the most often. Okay? So I really want you to pay particular attention to these and really consider if you already are utilizing or reporting on these. So just put in the chat box if you can. I'd love to see, are any of these already areas that you're already doing, pulling metrics and measurements from or reporting your information to? ASAM has a great paper already developed related to, in specific, what they want substance use programs to be measuring on an annual basis. And they've actually tied that into their value-based program recommendations to the federal government and to other states. So also states that are doing those substance use programs for the state, and in specific, really looking at this is your medical neighborhood for substance use programming. ASAM has made recommendations in specific of what those metrics need to look like. So these are a great place to start. Okay. In addition, consider creating stakeholder meetings. So typically we recommend doing this on an annual, once a year basis. You're going to use this meeting to obtain feedback, success stories. It's a way to improve your referral coordination, identify areas for measurement and successful growth and value attainment. This can also be where you're going to showcase all of the things that you've successfully met in this past year. Maybe you also introduce new providers, right? You can do patient showcase if you do any of those things for grants, etc. Ensure to take the time to check in on areas that you've already collected or learned about as far as your aims, and focus your metrics with your stakeholders. So you might actually ask them, what are the areas that we might be missing? Where should we focus on? And if you've already taken from these stakeholders, the specific metrics that you know that you want to really focus on and look, you might want to bring them up to these stakeholders who are different and say, what do you think of these areas? These are things that we want to project or collect data on and report on. It's a great time to really be very thoughtful in talking about these things and visible. One of the main real ethical standards related to metrics and measurements is to really talk to your stakeholders about what you are reporting and what does that look like. So this is a great opportunity to do that. Okay? Don't be surprised if these stakeholders identify different areas than are the national or international required areas for metrics. The next step here is to consider alignment and focus with your triple, quadruple, or what we now call quintuple aims of healthcare. So most people are familiar with the triple aims of healthcare: improving patient experience, quality of care outcomes, right? Satisfaction. But all of this is really important while also reducing your healthcare expenses overall and for your organization. Bodenheimer added this fourth aim, which is to improve the satisfaction of our teams and to always be looking at that for metrics and measurements. The ACA in the United States gave us the National Quality Strategy, which is actually highlighted here as well. Okay? This is aligned with our triple aims of healthcare and help us to ensure our focus in integrated care and substance use treatment is aligned with overall objectives of healthcare in the United States. This was also expanded through the Institute of Healthcare Improvement, or IHI, along with the support and recommendations from the US federal government, that they added a fifth aim of equity, enhanced equitable care. So really looking at equity measurements is now a new focus, and you'll be seeing that. You've probably seen it in the end of last year. You'll be seeing that all through the next years, and it's actually being tied in to now our value-based improvement metrics in the United States. The basics of US healthcare are built on these strategies, and this is a high time to be looking at this and making sure those things that you took from that stakeholders meeting, took from the national and international required metrics, you kind of pull through and make sure you have these lenses built on it too. In addition, once you've collected all of that information, it's time to meet strategically as your leadership team to ensure that all of that information you've collected, all of those possible metrics, are aligned with your mission, your community, your population. Okay. Now this is where you're strategically actually identifying, out of all these different types of metrics that people have suggested or that we know we need to be possibly reporting on, what are the ones we're really going to target and focus for the year? Okay. Once you have a solid sketch of this, then you're able to move forward with implementation and workflow planning. These are the typical areas that people do have metrics in. Typically, they'll have population health or clinical indicators as metrics. They'll have another standardized metric that's aligned with it. They'll have maybe a model-specific metric or access-specific metric, and they'll have something that's organizational, wellness, or equity-based. When you identify these metrics and have these measurements, your value is really communicated. It's tied to financial rewards. It's tied to ensuring and maintenance of any of your standards that you have. They help guide your performance, and they're going to be aligned with benchmarking. So meaning you're really going to need to ensure the alignment with monitoring and reporting is there. So creation of PDSAs or PDCAs, whatever you might want to do, is really important. So you may want to establish weekly or monthly reporting for preparation of quarterly reviews. As you consider your metrics, you also need to know how to do the reporting, how to write it out. Many of your national databases, if you're reporting already to them, they already have embedded into their spreadsheets or their online programs that you actually have to put your data into. They already have these mathematics built in for you, so you don't have to do it. But if you're not doing that and you want to start collecting this so you can show your value and grow even further, you're going to want to understand how to do this. So this is a standardized structure for metric reporting. You typically create the numerator as a specific key performance outcome and the denominator as a specific population. So here's an example, okay? And how you're going to do the mathematics is you're going to divide the numerator by the denominator. So here's an example, one, numerator, the number of individuals who initiate pharmacotherapy with at least one prescription for an opioid treatment medication within 30 days following an initial visit with a diagnosis of opioid dependence. Denominator, number of individuals with an index visit associated with an opioid dependence diagnosis after a 60-day clean period with no SUD claims. So it's really specific because this is one of the national metrics. So this is something you can consider. Okay, I'm just going to show you a few others. Number of MAT patients seen in X time frame. You're going to consider what that time frame might be. Denominator, MAT number of appointments available. Okay, overall. Okay, here's another one for tobacco in specific. Number of patients screened for tobacco use disorder. A number of patients with an SUD MAT diagnosis receiving addiction treatment. Okay, so thinking about the different populations and ways to really identify this. So again, this is how you would set up numerators and denominators with it. And as I noted before, I wanted to kind of give a highlight to some of these regular pieces of required metrics and things that people are doing. As we just reviewed, those are real metrics that are being used every day in substance use programs. And here's a few just to highlight. Okay, so here's some from CMS. So give you a few metrics that you can consider. We also have a few from National Quality Forum that I pulled for everybody to look at. These are all related to substance use. And these are all easily accessible for you to be able to pull and look at yourself as well from all of these organizations. Here's some from HEDIS. Again, this was from that earlier screen of national metric databases. Okay, these also have the indication of Medicaid. Now, we also know that there's been some changes related to use of waivers in our states, et cetera. So those things you really want to ensure that if you have any previous metrics related, that you've updated related to any of the new changes that they're noting federally. I have a sheet, if people are interested in, that actually lays out in an Excel file all of these different types of metric areas. But we want to plan to sustain all of these metrics and ensure that we're really monitoring for improvement. Typically, when we're first implementing it, we plan to assess and reassess at a 1 month, 3 month, 6 month, and 12-month basis, with really those weekly reports being fed into someone. So they're really ensuring that they have the data ready for that monthly meeting. Okay. So this is a way to consider it. I want to just stop here for a second and show you one of my other screens that we're going to actually give you the information for. So I'm going to pull that up really quickly so that you can see this. This is also something that we can send out. And I'm going to end here because I know I'm at time. But here is a database with SUD metrics for everybody to consider. And you see they're highlighted and it goes through all the different types of areas that are color coded. So that actually indicates the different types of metrics from the different companies that are out there. Okay, so Centers of Medicaid and Medicare, CMS. Okay, we also have different clinical care metrics listed, as well as communication and coordination of care metrics for substance use programs, as well as person and caregiver experience outcomes for substance use programs. And it goes through all aligning with the different areas that are recommended. Okay, so if folks are interested in this, we can also share that for folks as well, which might help you all in really starting to look at the development of your metrics. I also hope you take note of really thinking about all of these pieces of bringing together these stakeholders to really start with that. You might have to align with those nationally reported ones, but starting that process of really bringing home the stakeholders together to have those discussions is a really valuable process. So thank you all for your time today, and I wish you all luck in creating your metrics and measurements for the new year.
Great presentation. Thank you so much, Lesley. And yeah, you're getting cheers there in the chat. Everyone loves a good spreadsheet and a helpful resource too. So we look forward to sharing that. Questions for Lesley about this presentation?
Hi, this is Chandra from Communities for Recovery.
Thank
Hey,
you.
Jen.
Yeah, go ahead.
Hi, thank you so much for including such a wealth of information. It's quite a bit to digest. It's a lot that's really new for me, but it did pique my curiosity because when it comes to serving people who are deaf and hard of hearing, a lot of times what I'm asked is to get is to show proof that they even exist. And where they are and where they're needing services. And so I'm just wondering if this type of information or these resources are things that I could draw on when people are, telling me, well, we don't even know that there are deaf people who need, recovery support services anywhere. Can you prove it? Because we haven't seen them. Is this something that would be beneficial to me? Is this something I should reach out to you about?
So I'm kind of hearing two different things in there. So one
Okay.
is definitely, yes, when you're thinking about metrics and measurement, what you're going to be doing is looking at those and actually focusing it on your special population. And
Okay.
that's how you're going to be able to highlight your value and saying, yes, we have X amount of individuals that are coming in requesting access to care in this area. You may actually even be able to tap in. A lot of these national databases actually can show you, you can sign up for free for these on their websites, like through NCQA, National Clinical Quality. I'm saying it wrong. But and you can actually sign up and you'll go on to that organization and you'll get all of the metrics. You can download them, but you can also have access to some of the national metrics that have already been posted. And sometimes they'll actually have them listed by special populations.
Okay.
And you can see, are there other areas that have actually listed them by special populations? So the other thing I would probably recommend is reaching out to a larger, broader organization like ASAM and others, and specifically asking them, hey, what do we have for data related to these special populations? We need to ensure we're providing accessible care for all of our populations. And I would really focus in on that too, to see if they can give you some more data to really help with your value reporting as well. I'm wondering if others have suggestions too for Chandra. Any other suggestions from others?
As I was listening, I was thinking about the common dilemma that Chandra is describing, which is trying to find local data related to the prevalence. When Lesley was talking about that simple denominator question, how much of a certain something is happening within a community, and so it's hard to get local data. So can you get federal data or state data and then do the division for your own community, assuming that it reflects the broader state or federal data? And that's something that many folks have to do in this situation, because it's really tough to count some of these things in your local environment.
So there are some areas nationally. There is the national movement related to substance use medical homes. So not all states have gone through that, but some of them actually do have data related to deaf and hard of hearing populations. Georgia does. They have a substance abuse services for deaf and hard of hearing, and they actually have specific contracts, and they have data that they actually publish related to that. So I would probably encourage you to look at that and consider if there's other states that are providing that too, because there is data related to how there's more significant use in that population, and there's less access to services for that population. So I would look at some of those already, those states that are already actually pumping out some of the data.
Okay, that would be really helpful. Thank you guys for your feedback. I super appreciate it.
Yeah, and Chandra, I'll go Google really quick to see if I can find some direct links, and I'll put them in the chat for you, because I know that they exist in Georgia. So let me see if I can find some more, and I'll put them in the chat.
Yeah, absolutely. And I'll be honest, it doesn't, just because I have links to it, it doesn't mean I'll be able to understand or interpret what I'm looking at when I get to it, or what to do with that information. So I may still be reaching out to some of the people here to try and figure out what are the next steps. I appreciate that.
That's awesome.
Thank you very much. Thank you.
Yeah.
Great question, Chandra. Others? Lesley, I was wondering, when you were mentioning gathering stakeholders, and you mentioned that those stakeholders might identify priority areas that are different than, let's say, nationally recognized measures. Curious if you have any thoughts on how to reconcile those differences in priority.
Yeah, would you like me to speak to that?
Yeah, that'd be great.
So typically what I always like to say first, as you saw, I really did it strategically of how I would like people or recommend for people to walk through that process, and looking up some of those major pieces as far as HEDIS, NQF, UDS, ASAM metrics, et cetera, are great to first pull from and get those lists, like literally, like just print them out and then look at those and then do a highlight, which ones really address what we do, because some of them are just going to cross off, right? And then you're going to have have like kind of a focused area. Then you're going to walk into that community group and listen to what they have. Hear about what services they want. What do they know that you guys have been awesome at? Success stories, areas that we might be missing on. And that's going to develop areas for metrics and measurements for future success. Then bring up what you've recognized as far as from those other previous metrics that you've kind of come down to and said, here's some areas that we might want to consider. I might not show the exact metric because it says something like number 2605, follow-up for alcohol and drug service after emergency department visit, right? I might not write it like that, but I would write following up in a timely manner after emergency department visit related to this. I would write it so that the community that you're serving fully sees what your intention is. So having appointments available, following up on these records and see what do they say about those, if they like them, do they have comments about them, concerns about them, and then gaining that. So then after that meeting, then when you're meeting with your leadership team and really looking at the mission alignment, you're taking in all of that feedback together and really putting it through that piece of saying, what do we know that the communities have really come to us and said that these other stakeholders that they have questions, concerns about, what do they recommend, and have that list. How does that go with this list? Are they already included in some way, actually, right? And so then you can start crossing some off from that too. And then you can say, how is these that they've come up with really focus on our mission? Because some may or may not be. And then you're going to cross them off or highlight those as well. And then you actually should probably come up with this list at about 5 to 10 metrics in the end after walking through all of those digestions. You'll probably have that. And then you're going to want to look at that and say, what can we feasibly do? And what can we realistically do with our data? It may be that you want to do these, but you have no way to actually monitor it and pull the data because your EHR doesn't have that capability or you don't have the staff. So then you're going to walk through the realistic legitimacy of those next. Lindsay?
Yeah, I was just thinking for data on like deaf resources, the Travis County Services for Deaf and Hard of Hearing, they provide interpreting for things like AA meetings. And so they probably had to have some type of statistics and numbers to say, hey, we need this service, for the state to pay for it. So they probably have our good wealth of resources on that.
Great,
Awesome,
thank you.
Lindsay.
And Lesley, thanks for the walkthrough on the way, how to digest what feels like almost drinking from a fire hose of information you might want to be looking at. So, well, let's go on and move on. If questions do pop up, please use the chat to raise those, and we'll keep bringing them up throughout the session. But we'll move on with today's session with some announcements from the Be Well Texas program. Thank you, Kato. You read my mind. So if you're new to Be Well Texas, it is a welcoming environment with caring professionals ready to help people start or continue their journey to recovery. Be Well Texas is committed to expanding equitable access to compassionate, evidence-based care for substance use disorder all throughout Texas. Next slide. This is coming up very soon, so do join us for the 5th annual Texas Symposium on March 27th and 28th at the Henry B. Gonzalez Convention Center in San Antonio. So Texas is a free event and includes complimentary continuing education credits. Please do check them out. For more information, visit texas.org. That's TXSUS.org. We'll throw that link over into the chat. Next slide. Texas is also still accepting exhibitor and sponsorship applications. Please do consider this. 100% of the support they receive provides free continuing education credits for across the symposium for all attendees. It helps to fund travel grants for experts in the field and underwrite other event-related costs. You can learn more about this at texas.org/sponsor Texas. Again, check the chat for the link to that. Next slide. And we hope to see you at our next echo in this series. I guess in honor of tax season, we're going to be talking about audits, specifically preparing for successful ones with SUD treatment centers. And next slide. If you have been to our other echoes, you may have noticed that we've streamlined our process for taking attendance and for claiming educational credit. So all you need to do is text the code we're going to drop in the chat. And as we speak, and send that code to the number listed on the slide. you will receive a text confirming that your CE is ready for you to retrieve. So make sure that you text this code before midnight today. And if you're having any issues with this process, any questions about it, email the Be Well Texas team and they will get right back to you. That's bewelltx@uthscsa.edu. And Kato with Echo IT has just dropped these instructions over into the chat as well. That's all I have in ways of announcements. And today I'm going to pass the floor over to Aisha, who's going to be presenting our case for today. Aisha, Kato will pull up the case form you presented. When you're ready, please introduce yourself and bring these questions to this group.
Sure, thank you. Hi, I'm Aisha. Can you guys hear me?
Yes, we can.
Okay, perfect. So I'm Aisha. I work for a federally qualified healthcare center. I work as a program manager for our OBAT program here, which is office-based addiction treatment. And we operate on a completely fully integrated healthcare model, which includes primary care services in addition to the OBAT program. And the OBAT team that we have, it's not a very big program. We currently have about 40 active patients, and our team includes me as the manager. We have a care coordinator, a nurse practitioner, a counselor, and a peer recovery specialist. So before I move on to the case, I would want you to know that the case has like two parts. Something to do with policy making and policy implementation, and then patient confidentiality and ethics and how these two areas are interrelated specifically to this case. So we've had this patient who's been with us for about a year and a half now. And when he joined the program, he had several case management needs, and the entire team was working very closely with him. He had a strained relationship initially with his mother, which kind of got better. According to him, it got better. And then one day he tells us that since his mother is actively using, he would want her to enroll into the program. So we sat down as a team to decide, which we always do. And we thought that just because we have one care coordinator, one counselor, one nurse practitioner, so working with him and working with his mother could lead to maybe, a conflict, and it might not be good in patient's interest in terms of her care and his care too. So we decided, I met with his mom and I explained to her that this is the reason we can't take you into the program, but I would provide you with more community resources, which I did, and she was very understanding. So we decided that maybe this should be our policy, not to accept direct family members into the program, since we have a small care team. So, okay, life goes on, everything is good. We are working on this policy, and a month ago, I have this patient in my office, and I'm completing the intake with him, and I see that he doesn't have an emergency contact listed. So I asked him if he would want to add an emergency contact, and he goes, yes, I would want to add my sister. So I take details, her name, her address, and while I'm typing that, I realize that his sister is our active patient in the OBAT program. So my immediate response is, how did you hear about the program? And he said that through my girlfriend. My next question is, are any of your family members in our program? And he goes, no. So here I am in a conflict. According to our program policy, I cannot take him in the program because his sister is already in the program. But what do I tell him? I mean, I have to be mindful of his sister's confidentiality. I can't tell him that your sister is currently in the program. So I would really want to know from the experts here that what are your policies on getting, enrolling direct family members into the program, and if you've ever been in a situation like this. Thank you.
Thank you, Aisha. And I think the questions asked really beautifully for this audience. We'd like to hear from the group here. What are some of the policies that you all have found successful with enrolling of direct family members? And it also sounds like partners is another consideration as well, right?
I also would piggyback on that. And how did you come to those policies? Did they evolve? It sounds like as Aisha's did through the interactions, or did they come from, another source, maybe someone's ethics or organizational policy?
Yeah, so thank you for the question, Kathy. But yeah, I was just trying to be as brief as possible. It was not just one patient. It was many patients like this. There have been patients who've requested this, and then we have people in the group rooms who were strangers, but got into romantic relationships, and we had to kind of put them in different groups. And we realized that over time, this was creating problems, having either partners or direct family members into in the program. And then, of course, some expert advice from Kathy too, who suggested that we shouldn't have maybe partners in the program. And it's been helpful. We still do have a couple, because that was prior to the policy. We do have couples, but we have them in either different groups, or one of them is receiving group services and the other is just doing individuals. Yeah. Did that answer what you were asking, Kathy?
Yes, I just wanted to make sure that there was, folks understood that this was an evolving situation, and it's in all transparency. It's an organization that I've helped in the past with ethical quandaries and policy making.
And I think it's a helpful, maybe not reframing, but it's a helpful added push to Kathy, not just what you're doing, but the reasons why, like what's the decision making. That's what we'd really love to hear from the learners today. Lindsay, I see your hand. Go ahead.
Yeah, so my organization has run into similar issues. For us, it was all about staffing. If we have the ability to, see family members and things like that, and have them completely separated as far as staff goes, that's one thing. If we didn't have the staffing capacity for that, then I would imagine we would not be able to. It's because it's conflict of interest, right? You can't be helping or treating, whatever you want to call it, more than one family member at a time. And we go about it by just essentially saying, look, I'm really sorry, but at this time we can't qualify for this program. If in the future that changes, we can reach out and let you know. And just kind of a very broad general, right? Not, well, you have a family or something, anything like that. It's a very kind of generalized, I'm sorry, you're not accepted.
But they normally request, they want to know why they're not accepted in the program. And for this particular case, I couldn't really explain. I mean, I would say that we were lucky, but I didn't see him after that first week because he's incarcerated currently. But he is still on my patient list, and he is going to return probably after 2.5 months. And I don't know how am I supposed to go about that. Accept him or just deny, or how do I explain?
Also, we make sure that if we don't have the capacity for somebody, we are able to refer them out, and we actually sit with them and make sure that they, we go through that process with them and actually make the call with them, so that they're not just kind of shoved out the door.
That's right. We always do that. We never just tell them to go. We always give them resources, our peer services. They even make phone calls for them just so that they're accepted to the program.
Lindsay, I have a question. Are you urban or are you rural?
We are both.
Okay.
So we work in in Travis and Williamson counties, and Bastrop. So,
and we were talking about this earlier, that I feel like this is another question, because you do have the capacity to make that referral out, then you can do that. But there are some, or maybe people who are on this call who are in rural areas where there is no other resource for that.
Correct my pronunciation. Is it Mawish? I see your hand.
Yes, you're right. It's Mavish. Thank you so much for giving me a chance. Yes, I think I did hear Aisha and her case study. Thank you so much for bringing this up in the meeting. It's more like, when you are in the rural area, the underserved area, it's definitely very hard to provide the quality care to people who are actually looking for it. And it's timely sensitive, because we don't know whether this person really needs the care at the time, and when they're reaching out for help. I think that's even that first step is courageous on their behalf. So you definitely don't want to deny treatment, yet at the same time provide a kind of proper response that, hey, I want the best for you, yet we don't either have the capacity or the staff available. At the same time, also give them some sort of timeline that maybe within 2 weeks, maybe within 3 weeks or so, when possible discharges happening of that particular family member or somebody they know probably, could be a conflict of interest. So this patient is not, feeling that they are being refused treatment, right? So you are giving them that timely goal and at the same time helping them reach somebody they're already established with, like in the interim with their outpatient provider or somebody they're already seeing. So there is no gap in their treatment.
Thank you, Mavish.
Yeah, some really great guidance on kind of managing expectations and trying to maintain care as well. I saw another hand and then it went down. Lesley, go ahead. I see your actual hand.
I'm sorry. I was like, oh, I do want to say, I think, at least for my experience in our programs, we went through this. I wish I could say that we free thought about it before it ever happened and made great plans, but we didn't. When it happened, we were in knee deep in it, right? And we're in one group and we hear them, a member talking about another person in another group, not knowing, right? And even things about like how maybe someone in another group might be sharing their medication with them, right? So, this just happens. I think now just really sharing these experiences, we can learn from it more. Some of the things that we did is things that I think you're doing already and what people are explaining. We really started to think about pre-planning. How do we walk through and think about these to really make a formulated decision-making on it? Are there policies or procedures we need to put into place so we can fall back on that? And then we also talked about, and we used scripts, but that's because I'm a script person. I know Kathy knows this. We've done a lot of scripts together too, but I like those because I really like it. So it's the same thing our team members are saying to our patients. It sounds like you're really an open door policy, which is awesome. For us, we were too, but we also really made sure in our script, we made note that we're going to look at our capacity right after this intake. I go back and see what group might be the best fit. And if we don't have a best fit here, we will recommend these specific programs that would be a really good fit for you. So we're going to talk to you, and maybe it's in the next hour, or maybe we're going to call you right now, or maybe it's going to wait and we're going to come right back to you, or tomorrow. But we made scripts related to it so that we weren't caught in this, oh yeah, you can see through that there's probably a problem, hint, hint with that family member I just asked about, right? Because, people see through it really quick as much as we try to be covert about it. So we try to do a script so that it wasn't as highlighted. So then we could more naturally move them, but it just depends on how you want to go about that and what really you want as far as that presentation. But I'd love to hear from others. Do you all have scripts, and what other areas do you think through as far as that thought process? The critical area of staffing was noted. What about other areas too?
Well, there is a question, and is if Fernando is able to open his mic. He's had several suggestions and questions. Fernando, are you there? If not, we can read your post in the chat.
Yeah, because I went ahead and missed it. Is this an outpatient service or residential service?
It's OBAT, it's outpatient.
Okay.
Opposite.
Yeah, because one of my questions was why, instead of disclosing that the sister's in treatment, why don't you ask him? It's the male, right? That's in
Right. Mm-hmm.
Ask the male if he has any family members in treatment.
That's what I asked. That's what I said. I never mentioned his sister. I said if you have any direct family members in the program, and he said no.
Oh, okay. Yeah. So then the other, I guess what would come to my mind is maybe scheduling them in different days, different groups.
Yes.
So therefore,
That's a great suggestion. But what I have experienced is the group participants become such good friends, and someone might in the group tell him that, oh, your sister is part of the program too, right? So I know these are very tiny things, but we have to be mindful of everything and, just make sure.
And Aisha, I think there was also some concern by the prescriber about having a conflict of interest if she was seeing both family members, especially, and the counselor as well, because there had been a lot of conflict between the mother and the son that was disclosed in the counseling relationship prior to the OBAT services. So it was kind of a really complicated web that happens.
Right.
Great question. Carrie, I see your hand up there.
Hi. We're really rural. And we're the local mental health authority here. And so we have people, we're RSPS, but we're on the SUD side. So we have people that I'll use one specific, a mother and daughter, who are both in RSPS and SUD and the MAT program. How they do it here, they don't go to the same groups. Well, they really would prefer not to go to groups. So their counselor, they have them where they come different days. But like with us, I'm one of them's peer, but my coworker is the other peer. Like I don't have both of them. The counselors do the same thing. And I know like we have people that come that are related that I don't know, they're not on mine. They choose not to be an RSPS, but in our meetings, I've heard them talk and they schedule them for their group days to be different. So they're not in the same groups. And they have to, of course, don't ever have the same counselor. Now what happens on mental health side is another, because we're everything here. So but that's some of what we do to help keep the, what's it called? Conflict of interest out of it a little bit. So we do that, so.
It's interesting as I'm listening to some of the feedback, thank you for that, Carrie, that there's this scenario that we have with this situation, Aisha, which is that you have both the small staff size and the same day or kind of low threshold access where you don't have some of those screening opportunities which might present the chance to do some of this decision making earlier prior to engaging with the individual to start care. So to underscore what Lesley was describing as it relates to the decision tree or the decision process, that sequence, where and how can we explore some of these things? I think a lot of you are describing and maybe thinking about the ways that you do that and being very intentional with trying to manage that. But those two variables, size and a low threshold, and I'm a huge fan of low threshold to care, it does create an added challenge for you with this circumstance.
Thank you. But I do appreciate the feedback, having scripts and having a decision tree. I think that should really help. Because we do have a decision tree for our intake, but maybe just specifically addressing this would help for sure. Thank you.
I'll offer one more piece is we did think through in our area, we were fairly rural and we thought through whether or not we should look at, well, is there a thought process and if they're in a different group at our clinic system, will they still find out, right? But we actually just started thinking about that. We know patients can share information all the time and they can, they're always going to be talking, even if, they're talking outside the community or they're talking from another site that we've referred them to. We've heard our patients talk about, oh, Gary over there, he's going to ACL's one, right? So we get that all the time. So we decided that wasn't going to be a point for us, but we actually had a conversation about that. But we also know that at our sites, we see 1 out of every 3 people in the communities, and even our, referral centers that we might refer people to, again, right, the people that they're seeing are still our patients, right? And so we know the talk is still going to happen. So we just decided that wouldn't be a reason not to bring them into a different group. But that was ours. But again, we had to really walk through it and talk about it. And it was a pretty heated discussion. I'll just be honest about that, so.
I mean, I know it's too much to put for the group, but fine, even if you put them in different groups, right? But there was this one patient I told that I cannot accept your mom. If he finds out that he and his sister are in the program, he might just come to my office. Why not my mom and why him and her sister are here, right? I know as a program manager, I have to think like way ahead, right? So yeah,
and consistency can actually, or inconsistency can derail treatment, because they could feel it could bring up trauma, it could bring up all kinds of things and feel like they're being targeted. And then you add the cultural aspects where there are some families who really do engage their family members in all aspects of their treatment. So you can't make the assumption that just knowing that they're together or being in treatment together is going to be harmful. But you just have to go with what your guidelines say, with the assumption that if they do want to include their family members in their, knowing that they're in treatment and help with support, that would be fine, but you don't want to force it where it would create a problem. Looks like Carrie's got a comment.
Well, I was just gonna say, being rural, in a rural area like we are, can be hard, like, because I work here. My nephew went here, he passed away a few weeks ago, but like, he worked here. He came here, and I didn't know he came here because he only went to the other side. So I don't always see that. But I have a niece-in-law who is on our side. And so she came to me and she said, "You're not going to say anything," that side of it. I don't want her not to get the help and share because she thinks. And I said, I would never, ever do that to you on a personal level or my job. I would not do that, but my mom is, of course, their grandmother. So that sometimes is hard, because I never want to hinder somebody and them not share because they think. So I don't go to the group she goes to. I don't ever want to cross that, you know what I mean? But I'm always in my own head, and my boss says, "You're fine." But I get in my own head because I don't ever want to hinder somebody, because I work here and we're the only authority really locally she can go to. Sorry. So how would y'all handle that? How do you? Has anyone ever had to do that or deal with that?
Well, I feel like we're here at a place where we're thinking through some of these quandaries that require open communication, good therapeutic relationships, good boundary setting types of modeling, and, compassionate care. And as Lesley, noted, you want to provide equitable care as well. So some of these policies are meant to protect, but sometimes there's no way around it. So those open communications and just being compassionate and saying, let us help you work through it. And I think this is where family therapy should step in. I think family therapy should be part of a lot of these programs, because if you let this play out outside as you're trying to keep it from happening, then you're keeping them from getting additional support in the systems that would actually help them in their recovery. And I hope that made sense the way I said it. But as a family therapist, I think through that, you cannot just pluck someone out of a family system and treat them and then pluck them back in and expect that the system is not going to continue to do what it does. You have to treat everybody as a part of something or some group or some family, because that's who you are. And I'm so sorry to hear about your family member, Carrie. You're on mute. So I'm going to hand it back to the facilitator, and I didn't mean to talk for you, Aisha, but I feel strongly about that. And you and I had that conversation.
Thank you.
And maybe further underscores the importance of having making these decision trees so that you can rely on them. You can look to these in these more complicated moments. Fernando, I wanted to return. You had a question earlier in the chat, and I think the moment in the conversation has passed, but I want to make sure we answer that question around confidentiality rules. Would you mind unmuting and just sort of giving some more specifics? What kind of answer you're looking for there?
It's not really an answer, because in my experience, and I guess I'm not considering that we're in a rural area, because we have multiple counselors, we have multiple group days. And I guess, that's a limitation in her situation, because, whenever clients come into groups, we have to advise them that they have to protect other people's confidentiality. Even though it's beyond our control, but it's still one of the program guidelines. They can't go around telling other people, hey, this person's going to group with me, because that actually breaks that person's confidentiality.
That's right. Thank you, Fernando. And we do, when I'm doing the intake, I tell them that we highly appreciate if you're respectful of everyone's confidentiality. Having said that, we do not take the responsibility that whatever you share will stay in the group. That's how I put it to the patients.
I'd also like to just underscore the ingenuity and creativity of small rural service environments where privacy is really hard and there's only one blue Ford pickup truck in town. And if you park in our parking lot, everybody's going to know who you are. And those things are just challenging. And I just have worked with a number of organizations in those kinds of more rural environments where everybody knows everybody's car, et cetera, where you have to just, do a lot of ingenious, creative things to try to maintain a privacy standard, which is hard. And so I just want to appreciate the work that goes into trying to do that.
Yeah, and you're so right. We have so many participants who have actually started working together. They help each other get jobs. So you're right. Yeah.
They become their own community.
Yeah.
And we want that in a lot of ways too, right? Yeah. So, it's a hard balance, but I do want to emphasize the same thing, Matt, that you just said too, is, as what was shared earlier with family members and other dynamics that occur, that decision-making and walking through how, I won't be attending that. That's great. That's perfect. And yes, we all know that we would all have really high ethics and standards and we wouldn't be disclosing anything, but it's wonderful when we walk through that decision-making, we see it and we say, we're going to do everything we can to ensure that we're not going to be creating opportunities for anyone to be uncomfortable. Right. And I think that's really worthwhile. And I really commend everyone for thinking through these pieces.
That's really beautifully summarized. We're coming up on the end of the hour, and it is interesting. I'm hearing about how important that decision tree is, but also how nuanced and unique it can be. So thanks to everybody for sort of sharing the thought work that goes into your own, whether that has to do with your location or your own staffing capacity, availability of local resources, and more. I think that's really, really helpful in helping the groups on this call kind of think through what their own plan might be. I'm going to turn it now to Kathy to summarize key points from our conversation today.
Ooh, I would have this time. There's so much. Okay, starting with our didactic, just to sort of summarize a little bit of what Lesley presented, identify your metrics to demonstrate value. Make sure that you're balancing your priority areas, your stakeholders' priorities, your focus areas, your mission, and those metrics that are required by your organization and from your state and federal government and your funders. Also, really try to intentionally have those stakeholder meetings to include all the voices of the folks that you serve, as well as anyone who has a stake in your organization and the outcomes. Look at all the clinical measures and the standardization and organizational measures. She told you how to set up a metric, which was amazing. Numerator, denominator. I can't wait to play with that later. Plan for sustainability, and then consider your special populations, especially when you are identifying those of your most vulnerable populations. Now for the case, wow. So a lot of the recommendations were centered around staffing levels, consider those levels, how to make those decisions, get a process in place, make referrals out if possible. You may need to get really creative with your scheduling, like many of the rural areas do, to maintain confidentiality and privacy. Make some contingency planning if you really can't refer out, if you, especially if you were in those small areas. Another big factor here is the low access threshold. Make sure that you understand before you take on that type of philosophy, or if that's part of your requirements for your program, that you understand that these quandaries will come up, and make sure that those policies are very clear and communicated as much as possible, and be consistent when possible, and have open communication when these issues come up and they're not easily solved.
Wonderful wrap up. Thank you so much, Kathy. I want to thank all of you for joining today's session. There was a really important question in the chat. I want to make sure I answer for anybody who's not eyeing that. You do need to create an account to obtain CE. If you start to follow those links, you'll get that information. You only need to do that once for this series, for all series through the Be Well Texas program. So do that once. It's a pretty quick process. And then after that, your CE will come even faster. So thank you all so much. Thank you to Aisha for bringing this case to us and to our hub team for the great presentation and conversation. Above all, thanks to all of you who keep showing up and making this space what it is, where we all teach and we all learn and we all share. I hope you have a great rest of your day. We'll see you again in March at the March 23rd session. Happy Thursday, everyone.
Bye, everybody. Thank you so much.
Bye.
Thanks, Aisha.